Hi, I'm Wendy, and today we're going to discuss the different types of shoulder replacements, as well as OT evaluation and OT interventions for these patients. So we have three types of shoulder replacements. There's a total shoulder, a reverse total shoulder, and a partial shoulder. So with all of these, we have the humerus here, and this is on the shoulder blade. And that would look similar to this. This is the head of the humerus, and this is the socket that's on the shoulder blade. So the head of the humerus has rotation, flexion, extension, all within here because this is flat, so it allows for more movement. So with a total shoulder, they remove the ball or the head of the humerus, and put a metal or titanium ball on there. And they also replace the socket, which is attached to the shoulder blade. So with a total shoulder, both of those are replaced. Reverse total shoulder is just reverse of that. So once they take off the humeral head, they replace it with a socket, and the ball is attached to the shoulder blade. They do have different precautions in general for the two types of surgery. And with a partial, typically if they're doing a partial, the socket is still works fine in the patient, but the ball or the head of the humerus needs to be replaced. So they'll replace that just like they did with the total, and they may do a little bit of work to clean up the socket, but generally it's just the ball that's replaced with a partial. Shoulder replacements have a pretty extensive recovery period. So phase 1 is 1 to 4 weeks. In this phase, there's no weight bearing, no active range of motion. The arm is in a sling for all out of bed activities, and no showering until permitted by the surgeon. Passive range of motion may be allowed by the surgeon. It's very important to get the protocols for from the patient's surgeon. Phase 2 is 4 to 6 weeks. In this phase, there's no heavy lifting or weight bearing. They can start to phase out the use of the sling as directed by the surgeon, and minimal active range of motion exercises may be directed by the OT. Phase 3 is 6 to 12 weeks. In this phase, there's no lifting greater than 5 pounds, no sudden jerky movements on the operative arm, and gradual active range of motion, again as directed by the OT. You can start to include strengthening and endurance exercises while maintaining the lifting precautions. And phase 4 is 12 or more weeks. In this phase, generally the weight-bearing precautions are lifted, no more wearing the sling, and they can begin active range of motion, strengthening, functional activity tolerance, and functional mobility on the postoperative shoulder. The OT evaluation is very important to help determine the patient's prior level of function. We have to know if they were independent prior to the surgery or the injury. Their medical history. If they have diabetes or heart problems, they may have a longer recovery process, so it's important to know what you're up against with that. You're going to build an OT profile. And this would include the patient's priorities, interests, and therapy goals. And then the OT can help design a plan of care that will suit the patient's needs. Pain levels at rest and with exertion are important. Their cognition and mental health. It's important to know if they're able to follow their weight-bearing precautions and movement precautions. Keep with the active range of motion and passive range of motion of the non-operative arm. They're going to be doing a lot of things with one arm, so we want to make sure that they are still using that arm properly. Functional mobility and transfers. How well can they do transfers and mobility with one arm? Sitting and standing balance. Determine their risk for falls. And you also want to find out how many falls have they had over the past year, and have those falls caused injury. What's their social support system? Do they have family members to help them? They will be pretty limited with most ADLs and IADLs, so it's important to have a strong support system. And then an environmental assessment to be sure they have the necessary equipment, grab bars, and things like that to make it safer for them. So the OT interventions would focus on the ADL performance, functional mobility training with their precautions, pain management techniques. It's important to continue to move the, not necessarily the shoulder in the beginning, but move the hand, and the elbow can be moved to prevent those from getting too tight. Manual therapy, passive range of motion, a lymphatic massage will help increase functional range and minimize pain. Following the surgeon's protocol for active range of motion, fine motor and gross motor activities while maintaining those precautions are important. Physical agent modalities can help reduce pain, and family and caregiver education and training to help the patient carry over exercises, restorative strategies, and lifestyle modifications. Thank you.